So, good evening, everyone, and welcome to Mahamana Case Discussion Series. For today's session, we have Dr. Prathamesh Pai. He's Director of Head Neck Cancer Institute in Mumbai. And he has been the first person who has been starting and working upon and teaching so many people for skull-based oncology in our country. So we welcome you, sir. And he'll be speaking on assessment of paranasal sinus tumors, contemporary management. Welcome, sir.
Thank you, Asim. I need to share my screen.
Yes, sir, you can do now.
Can you see the screen now?
Yes, sir.
Okay. So when Asim asked me to speak on paranasal sinus tumors, I thought I should be speaking on something which is very basic, which I felt that helped me during my learning process of paranasal sinus tumor management. And this is important going ahead, understanding how you have to do a case selection. How do you actually manage prior to doing any surgery or intervention? And remember, the multidisciplinary team is very important in the management of paranasal sinus tumors, and we cannot avoid having an entire team manage this. Now, we all know about skull-based tumors, and they are in between the neurocranium and the viscerocranium. And it involves the entire gamut from the frontal sinus right up to the occiput. And we are today trying to understand how to deal with the paranasal sinus tumors, which form the anterior skull base. So you will have tumors from the sinonasal tract, from the skin of the face and skull, orbit, bone, dura, and blood vessels, all which will come in the vicinity of these regions, the ethmoids, the frontal bone, the orbit, the maxilla, and the sphenoid. So when you are dealing with this kind of tumors, the most common pathologies that we deal with are the squamous cell cancers, followed by the adenoid cystic tumors and the neuroendocrine tumors. Amongst benign tumors, you have the fibroosseous tumors, inverting papillomas, and of course, angiofibromas. So when it comes to the anterior skull base, I truly believe that we need to focus on anatomy, doing a proper clinical evaluation, reading the scans ourselves. Please do not depend on the radiology alone, because understanding the scans helps you in forming a game plan and achieving that goal. And it's very important that you need to understand the scans, because when you get a poorly done scan, it will not help you in your management. And it may be that fine assessment at the end that will determine the outcomes of the patient. Many times in the multidisciplinary team, we find our clinicians pick up points on the scans, which we then corroborate with the radiologist. And that really helps us. The Sarbani is there, and she also, points out certain things just looking at the scan, and that comes only by reading scans again and again and again. And for the surgeons in the audience, you need to do cadaver dissection. These are sites where we do not deal with routinely. So we pay less attention to the anatomy, and further so we do not see open surgery nowadays. So I would suggest you all spend more time doing cadaver dissection so that you all understand the nuances of the spread of the disease. Look at what are the important structures that are involved and how we can actually delineate the tumors and try and protect them. If you understand the anatomy well, it will also help your team, because the radiation oncologist also will ask you during the treatment planning what structures might be important to protect, which structures are required to radiate. And if you are reading the scans yourself, this is something that will help us all. And finally, understanding the disease, the extent of spread, will help you plan your surgical approach. So clinical evaluation is sacrosanct. You cannot avoid this. And if you do not document carefully, you will create problems for your patient. So we will look at the nose and paranasal sinuses, and often we forget the orbit. So you get subtle signs where the orbit might be involved clinically and radiology doesn't show it. And you might operate this patient and leave behind tumor. Look at the vision, which is very important, document it. Look at the cranial nerves. Very often we will understand more because the subtle signs, such as a early numbness of the canine, will tell you that the anterior wall is involved on the maxillary sinus. You might not see that on the imaging. If the patient tells you that he has numbness over the molars or on the palate, you know that posterior superior alveolar nerves might be involved. And this might be critical in that decision making. And finally, please do a nasal endoscopy. You will be surprised to see how often you might have considered an open approach, but an endonasal approach was suitable because the tumor is not really involving the regions where you felt that open surgery was required. Now, often we debate whether only a CT or MRI. Please get both because CT and MRI are complementary. Look at the CT scan on top. You might find that this area was looking like a soft tissue mass and reported by the radiologist as a soft tissue mass involving the frontal sinus and involving the orbit. When you do an imaging like an MRI, the simple T2 weighted image will tell you that that's an inspissated secretion. So you know that this was not a soft tissue mass, but it was just fluid. And you know that if you could do just a frontoethmoidectomy, there was sufficient rather than plan for a craniofacial resection. So it's very important that you get both CT and MRI because we want proper delineation of the bone, the soft tissue, the brain, the dura, as well as the eye. Now the sinuses. Most of the tumors which are involving the nose or the nasoethmoid region will block the sinuses. And often we will get the scans which suggest that the tumor is more extensive. Very often you find that the patients come to you with history of a few months of nasal blockage. And it may not really be involving the maxillary sinus. We are taught that the most common cancer in the nose and the paranasal sinuses are squamous cancers. But believe me, most of them are non-squamous. In most World Series, 70% of these tumors are non-squamous. So you might have a tumor which is involving the middle meatus or it's coming from the ethmoid, but it has blocked the maxillary sinus and hence causing an illusion that this patient has involvement of the maxillary sinus. Often the sphenoethmoid recess, a tiny recess, gets blocked early on, and the patient will manifest with a thick inspissated secretion or maybe a proteinaceous material within the sphenoid, giving us a false impression. Next most important consideration is that of the dura. You would have a CT scan which shows that the cribriform is eroded and that there is an intracranial spread. But truly, is it an intracranial spread? Is it an intradural extension? That you will get better information on an imaging. And when we talk of dural involvement, there are certain considerations. Is there a nodularity on the dura? Is there an enhancement on the dura? Is it really breached the dura? So these considerations need to be placed. Is it really involving the arachnoid? Because once the dura is breached and going into the arachnoid space, only then it can cross the barrier into the brain. Very often these tumors are subcranial, and more than 70% of tumors in our series were subcranial. So you would get away without need for a craniofacial resection though such a scan might suggest that you need to do a craniofacial. Now, intracranial extension is best noted with an MRI. Very often you find an intracranial extension seen, but due to partial voluming effect, you might get a false impression that it is intracranial and intradural. So study your coronal images, study your axial images, and you will be surprised to see how these are falsely interpreted. You can see this scan where the tumor had blocked the frontal sinus and caused a huge mucocele. And this was an entire blockage of the frontal sinus, which was reported as an intracranial spread. So this would require just a subcranial access or at the most a frontal access on the right side and giving a complete clearance of disease. Very often we are seen with, in this case, a rhabdomyosarcoma which was resistant to chemotherapy and was sent to us for opinion. On the first sight, this looks like a inoperable disease. But when you do the scan, you realize that this was entirely an subcranial pathology and it was hanging from the nose out. You could see that it had eroded the cribriform at one location and was only intracranial extradural at one point. So this patient required a complete resection, and we could actually do a proper surgery for him and avoid calling it palliative. So study your scans carefully. Do not lose your focus on operability. There are certain tumors that are operable. There are certain tumors that are worth doing, though they might appear inoperable at first visit. Now, when we are looking at tumors which are paramedial and medial to the middle turbinate, we are looking at a group of tumors such as a neuroendocrine or a esthesioneuroblastoma or a SNUC, or sinonasal undifferentiated carcinoma, which can all come in this vicinity. We need to do a multiplanar imaging to understand how much is the extent inside the brain and how much of it is involving the structures around. Again, a multiplanar imaging, axial, coronal, and sagittal will give you a better understanding of how this disease is spreading. You can see this esthesioneuroblastoma was having a very minimal extension intracranially, and it was paramedial. So you know that you could get away with either a Rave's approach, which is a subcranial access, or an endonasal access with endonasal craniectomy. Orbit is something which it requires a lot of persistence in order to understand where is it involved. The orbit can be involved either anteriorly or posteriorly. Now, near the apex and near the anterior end, it makes a big difference between operable and inoperable. Now, when you look at this scan, you can see that your lesion was eroding the lamina papracia on the right side. And an MRI will actually delineate this very well. You want to know whether this patient has an intraorbital extension or is it having just an involvement of the lamina papracia. When we are planning to do surgery for this patient, due consideration has to be placed whether this fat pad is breached. So if you do an MRI, you will know whether this is actually limited only to the bone or it has breached the periorbita and come inside the orbit. Now, this patient would be counseled that we will examine the periorbita intraoperative, and if we find that there is a breach of the periorbita, then we would have to consider doing a frozen section on the fat. Now, when we study this on MRI, we'll be sure whether there's actually a fat pad involvement in most cases. On the other hand, when there is an image like this, you know that not only is it breached the orbit, it has gone posterior and it is coming at the orbital apex. What it means is that at the orbital apex, when you are resecting, you might have disease coming on to the cavernous sinus. You will have disease coming onto the ophthalmic artery, which is a branch of the internal carotid artery. So you know that if you have disease involving the orbital apex, these cases might be inoperable. They might not be safe to operate because you will violate the zone and you might encounter heavy bleeding because of involvement of the internal carotid artery. So whenever you're studying the scans, be careful, look at the entire orbit in both the planes, anterior, posterior, and try to make that judgment and that call whether this patient is worth resecting. Finally, you need to look at the incurable lesions. When there is gross intracranial spread, when there's involving both the orbits, when there's involvement of the internal carotid artery, involvement of the cavernous sinus, extensive involvement of the pterygopalatine region. You can see in this case, the entire pterygopalatine area is involved. Now, these are potentially, these are incurable. They're not borderline resectable or resectable lesions. The first thing that you need to do on your paranasal sinus scans is look at the axial scans and look at the pterygopalatine. If your pterygopalatine lesion is involved and it is not a favorable histology, it is an inoperable disease. So today, if you see sinonasal or anterior skull-based tumors, most important consideration would be, is it subcranial or is it transcranial? Once you make this differentiation, it becomes very clear what would be your next step in the algorithm. Now you want to see if it is subcranial, what are the structures involved? Because you know that you can actually do a resection of these via a subcranial access or using a combination of transcranial. So for a subcranial pathology, how do you know whether you will do an open or whether you do an endoscopic approach? So if your anterior facial skeleton, that is the anterior wall of the frontal sinus, the nasal bones, the glabella, the anterior wall of the maxillary sinus, the nasolacrimal duct, if they are involved, these cases are not suitable for an open approach. If they are free, you can consider doing an endonasal approach. Now, if the palate is involved, so that's where the role of endoscopy comes in. If you do an endoscopy examination and you find that the entire tumor is free off the floor of the nose, it is free of posteriorly of the soft palate, you know that these are suitable for an endoscopic approach. But if it is involved, please do not waste your time doing an endonasal approach. Plan for a proper open approach. Now, if your tumor is transcranial, you need to have two accesses possible. Either you do it completely endonasally or do your combination with an open approach, which is an open craniofacial resection. Now, in this, if you have a large intracranial lesion but a small endonasal approach, you can do an endoscopic endonasal craniectomy. But on the other hand, if you have got a paramedian approach and you can resect the nasal part completely, you can do endoscopic endonasal craniectomy. So look at the intracranial part. Is it too large? Is it crossing across into the major brain matter? But on the other hand, the nasal part is small. Then you can do a combination. If the nasal component is large, it's involving the anterior facial skeleton, and the intracranial component is large, you have to do an open approach or an open craniofacial resection. Another consideration is about the tumors which cross the mid-pupillary line. So if you find that the tumor is crossed and involving the dura beyond the mid-pupillary line, today you know that you cannot resect this technically through the nose, and you will fail with the dural margins in the far lateral region. So not only will this make your reconstruction difficult, your margins also will be affected. So if you have lesions crossing this, you should consider doing an open approach. So today, your indication for an endoscopic approach would be tumors of the nasal cavity and ethmoids. And the contraindication for an endonasal approach would be an anterior facial skeletal involvement, floor of the nose or palatal involvement, intraconal orbit or the nasolacrimal duct system, extensive involvement of the nasopharynx, dural invasion lateral to the meridian of the orbit, and gross brain invasion. So look out for these things and you will be able to make a proper judgment. Another thought is about histology. So you looked at the anatomical extent, try to understand whether you can make a decision based on the histology. This is a paper that I urge all of you all to read. It was a prognostic study on 1360 patients based on sinonasal tumors undergoing endoscopic resection. Now, when you look at these, you find that the most common tumors are the adenocarcinomas, and in most series, they are non-squamous. So when you look at all these histologies, you realize that the ones that do very well are the adenocarcinomas, and the ones that do poorest are the melanomas and the squamous cell cancers. Again, extent of the spread. If it is involving the brain or the orbit, the survival is poor. If it is involving postlateral, but the orbit and brain are free, it is not seemingly affecting the outcomes. This also reflected in the international collaborative study group, wherein more than 2,800 patients have been accrued, and now this paper has been published in the Head and Neck recently in April. We find that more than 50% of these patients were now resected endoscopically, and the ethmoid and the maxillary ethmoid and the nasal cavity form a large proportion of these tumors. Again, adenocarcinomas do exceedingly well in contrast to these squamous cell cancers. There is an improvement in the survival because we are now steadfastly studying our scans carefully, picking out the right histology, and also looking at standardization of the surgical approach. And that is the key to achieving a good outcome. So standard surgical approach, standard post-operative radiation, and possibly considerations of chemotherapy are coming in a major way. So we know that you need to look at the scans, look at the histology, and then in an MDT, plan out the best treatment for your patient. Thank you very much for a very patient listening.
Thank you so much
to answer any questions.
Yeah, it was really great lecture for us, all of us. And if anybody has any questions or doubts, you can please put up in the chat box.
Asim, you can take that during the question answer session, I guess.
Yes, sir. So for the case presentation, we have Dr. Sumit Mahajan. He's a head neck resident at Kidwai Memorial Institute of Oncology, Bangalore. I would like to welcome all the examiners. We have Dr. Kapil Sikka. He is a professor in head neck oncology at All India Institute of Medical Sciences, New Delhi. We have Dr. Sarbani Ghosh Lashkar. She is a professor of radiation oncology at Tata Memorial Hospital, Mumbai. And we have Dr. Narayan Subramaniam. He's a senior consultant head neck surgeon at Sparsh Hospital, Bangalore. And I also request Dr. Prathamesh Pai sir to please join for the discussion. Sumit. Sumit, can you please start your presentation?
Yeah, good evening, sir.
Yeah, good evening. Please.
Sir, is it visible, sir, my presentation?
Yeah, you can just put it on the presentation mode
Okay.
in this part.
Shall I start, sir?
Yes, please, you can start.
My patient is 76-year-old male patient, a resident of Tamil Nadu. Patient worked in textile industry in the Tamil Nadu for 30 years, belonged to middle socioeconomic status, presented with the chief complaints of left-sided nasal blockage for the last 1 year, intermittent left-sided nasal bleeding for the last 6 months, and oral ulceration and facial swelling left side for the last 3 months. Patient was apparently history of present illness. Patient was apparently all right 1 year back when he developed left-sided nasal obstruction, which was insidious in onset, gradually progressive in nature. It present throughout the day, initially sometimes relieved by using over-the-counter topical medications. There was associated occasional scanty bleeding from the left-sided nasal cavity from the last 6 months, which used to stop simultaneously. Patient developed left side cheek swelling 3 months back, which was insidious in onset, gradually progressive, and associated with pain. There is no ulceration or discharge from the swelling. Patient also noticed ulceration over left side of hard palate 3 months back, which was initially very small in size and progressed to current size. There is no pain or bleeding associated with ulceration. There is associated history of left-sided headache since 3 months, insidious in onset, progressive in nature, dull aching, not relieved by taking medications. There is no diurnal variation and is not associated with nausea, vomiting, or giddiness. There is also history of watering from left eye since 3 months. History of decreased perception of smell since last 2 months. There is no pain in eyes, protrusion of eye or double vision or blurring of vision. There is no history of nasal discharge. There is no history of loss of face sensations or tingling or numbness. There is no history of reduced mouth opening or restricted jaw movements. No history of earache or discharge or reduced hearing. There is no history of vomiting or dizziness. There is no history of neck swelling. No history of fever, cough, breathlessness, blood in sputum, or bone pains. There is no history of weight loss or decreased appetite.
Can we give a small pause here and can you
Yes.
summarize what is the positive history here and what comes to your mind? What patient?
Sir, patient is having left-sided nasal obstruction for the last 1 year. Nasal bleeding left.
What is the age
Yes.
of the patient?
Sir, 76-year-old male patient, sir.
Okay.
And the patient is also having, sir, intermittent nasal bleeding left side and facial swelling and palate ulceration, sir.
So when you say facial swelling,
Ma'am, cheek swelling, ma'am, left side.
anything around the orbit?
No, ma'am. It was in the infraorbital region, ma'am, and around the orbit, ma'am. There are, ma'am. Orbit is normally in examination. The swelling is in the infraorbital region, ma'am.
So it's over the malar prominence.
Ma'am, it is just 1 centimeter short of the inferior, that middle canthus, obliterating the nasofacial groove, ma'am.
Okay. Nasofacial groove. Okay.
Nasomaxillary groove, ma'am.
From
Okay.
history, can you tell us whether you are looking at some benign pathology or malignant pathology? Are there some features which are telling you it's a malignancy? Second question I want
Sir,
to ask is you have said in one of the slides that there is no discharge.
Yes,
and
sir.
you have said that he has on and off epistaxis. So
Yes,
is
sir.
it a frank nasal bleeding that is coming or
No,
is it a blood
no,
thin
sir.
discharge that is coming?
No, sir. The bleeding was 1 or 2 episode in a month, sir. About 7 to 8 drops, as told by the patient, and 7 to 8 drops in 1 episode, and it used to stop simultaneously. It is only for the last 6 months, once in a month, sir.
But he doesn't have a discharge.
No, sir. He is not giving history of any nasal discharge, sir. And
What is history telling you? What points in history are telling you that you are looking at a malignant pathology?
Sir, first is the age of the patient, sir. And sir, one is the age of the patient. Sir, second is the patient is having, sir, from the history, he also worked in the cotton textile industry for the long years, 35 years, sir. And then patient is having cheek swelling and there is palate ulceration also, sir. That
Can you describe the pain in a little more detail?
Yes, that's important. You have said that he has headache,
yes, sir.
he has pain. Just elaborate on what type of headache is it and what type
Sir,
of...
it was a dull aching a type of headache, remains almost same throughout the day, and there was a patient is also having a headache and the pain over the cheek, sir. Constant dull, boring headache, sir.
Is it radiating to anywhere else in
No,
the
no, no, sir.
face?
No, sir. It was not radiating. Patient complains of heaviness and dull aching headache over the frontal as well as over the occipital region, sir.
Okay, how severe is it? Does it disrupt sleep?
Sir, it was mild, dull aching pain, sir. Remains constant throughout the day for the last 3 to 4 months, sir.
Okay, one thing that's also helpful in this situation is that you need to differentiate between this and trigeminal neuralgia. So you have to make it clear to the examiner,
Right, sir.
in terms of aggravating factors and things like that, that this is not the same as a trigeminal neuralgia, because many of these sinonasal cancers come to us advanced, but
Yes,
early
sir.
on they may mimic trigeminal neuralgia and be missed.
Yes, sir.
So
That is
how you describe the pain is very, very important.
Yeah, so that is in mostly in the sir temporoparietal neuralgia, temporoparietal region, sir, trigeminal. But the patient here complains of sir anterior frontal and that occipital, sir, dull aching pain, sir.
So just for benefit of younger audience, the causes for pain can be multifactorial. In maxillary and sinus cancers, they can be because of direct tumor spread to dura, which of course comes to your mind when you think about pain. Second, as sir alluded to, is can be neuralgia. It can be trigeminal and can be anterior ethmoidal neuralgia also. And thirdly, it can be because of secondary sinusitis. Sir had very nicely described in his presentation about secondary sinusitis and mucocele formations. So don't forget that it can cause sinusitis in non-involved sinuses and it can cause pain.
Yes.
Describe the character and describe where is it exactly. And you should also describe on when it appears in the morning, evening, or it remains throughout the day.
Right.
Yes, you can proceed, please.
And that temporal relationship is very, very important. So the patient has had symptoms for a long time. Did the nasal discharge appear first? Then did the pain come on? Or things like that will help us understand a little better. Is it only when, for example, palatal involvement was there that the patient had pain? Or was it because of mucocele or repeated sinus infections? So where the pain came, did it wax or wane? All of that gives us a lot of clues to what the underlying pathology is.
Hello.
Shall I proceed?
Yes.
Sir, past history. Patient is a known hypertensive and diabetic since last 15 years, sir. On oral antihypertensive and oral hypoglycemic drugs for the last 15 years. There is no history of tuberculosis, asthma, thyroid disorders or drug allergy, sir. No history of surgery in the past or prolonged hospitalization in this patient, sir.
Why did you talk about thyroid disorders?
Ma'am, if we are planning to operate this patient, ma'am, in all the patients we have to take if the patient is euthyroid, hypothyroid or hypothyroid, we have to take the history from the patient and accordingly we have to investigate the patient, ma'am.
Okay. But when you take histories, there's sometimes a habit to just rattle off all kind of negative history. And it's very important to understand why you're taking that negative history. Just now you're talking about, what is his age you said?
Ma'am, 76.
76.
Yes, yes, ma'am.
Okay. 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 Okay.
Sorry, one point also I wanted to make, if you don't mind. If you can go back to your negative history, no?
Yes, sir.
You've listed multiple things in the clinical history. It's very important to group them together. So if you can group together symptoms of local extension, group together metastatic symptoms, then it's much easier for the examiner to understand where you're going with everything. You mentioned everything, but if you just organize it and group it a little better, then it's very clear what you're trying to establish. Immediately, the examiner understands what's on your mind.
Right, sir.
Yeah, please go ahead.
Sir, with personal history, patient is a chronic, sir, BD smoker, used to smoke 20 BDs per day for the last 30 years, sir. Is non-alcoholic, non-vegetarian, normal bowel bladder habits, and normal sleep and appetite, sir.
Can it be a smoking related cancer?
Yes, sir, it can be. Smoking can be additive to other things, and solely smoking can be a cause, sir.
Hello,
Hello?
hello. Can you hear me?
Yes, sir. Yes, sir.
You can hear me, Sumit?
Yes, sir. Yes, sir. Yes, sir.
Yeah, this is Dr. Shinoy. See,
Yes,
you
sir.
should,
Good evening, sir.
you know that you're dealing with a sinonasal cancer. So
Yes.
go for some relevant history, which may say, you said cotton industry. Any other industries are associated with the sinonasal cancers, especially
Yes.
adenocarcinoma? Tell us that as a negative history.
Okay,
Tell us
sir.
that as a negative history. Any history of snuff?
No, sir. There is no history.
So that is more important than thyroid. Thyroid, you can ask as a question before you go for the PSC or something like that, if you see a high elevated TSH or something. But routinely, you don't ask people thyroid. See, your Viva will start taking a different route, and then you will be left answering thyroid question rather than sinonasal. So be very careful. Your history should tailor it to what you're getting yourself into. You're narrowing it down towards the sinonasal. Talk about areas which are neighboring areas and talk about symptomology there. You talked about trigeminal. Okay. What about orbit? What about ear? What about intracranial thing?
Sir, that I have told in history, sir.
Okay, you have said. Okay,
yes, sir,
so I
yes.
got in a little late, so I'm just
Yes.
telling you things. Yeah.
Yes. Sir,
So
proceed.
what
Yes,
is
sir.
your how have you zeroed in now? What is your provisional diagnosis?
Sir, from the history, sir, my provisional diagnosis is most probably I am dealing with, sir, sinonasal malignancy, left side, sir. Most probably maxillary CA, sir.
Maxillary only or maxillary ethmoidal or maxillary restricted to the maxilla, or it is
Sir,
extraantral also?
Sir, from the history and sir, from the history only, I think it is maxillary CA and maxillary CA with the that advanced, sir. With
Sumit,
erosion.
do you have a clinical photograph of the patient?
Yes,
please?
sir. Yes, sir. Yes, sir. I am showing, sir. Next slide.
Please.
Sir, general physical examination, sir. Patient is moderately built, ECOG 1, conscious, cooperative oriented, sir. BP pulse stable, sir. And no pallor icterus, cyanosis, clubbing, generalized lymphadenopathy, and pedal edema, sir. Sir, local examination. This is the picture of the patient, sir.
Okay.
Sir, on inspection, there is a edema over the dorsum of the nose, sir. No visible injury or scar. There is a diffuse swelling of approximately, sir, 3.5 into 3.5 centimeter over left cheek region. Superomedially, sir, about 1 centimeter short of the left medial canthus. Medially obliterating the nasomaxillary groove. Laterally, sir, 1.5 to 2 centimeter short of zygoma. And inferiorly reaching the level of the ala of the nose, sir. And the overlying skin appears normal, sir.
Did you pinch the skin?
Yes, sir.
So there is only the fullness, but skin doesn't seem
Sir,
involved.
skin is pinchable, sir. Skin over the overlying the swelling is pinchable, sir. There is no induration or tethering of the skin, sir.
I noticed there is some discharge, or I'm just assuming, on the medial cancer region. Is that purulent?
Sir, on pressing that purulent secretions coming, sir, it is mostly suggestive of dacrocystitis, sir. Then I'll present next, sir. Ocular examination, I will.
Okay.
Should I proceed, sir?
Yes.
Yes.
Sir, on palpation, inspectory findings confirmed. There is a firm swelling of approximately 3.5 into 3.5 size palpated over the left cheek, extending from the pyriform aperture on left side to superior medially 1 centimeter short of left medial canthus and inferior orbital rim, laterally 1.5 centimeter away from zygoma and inferiorly till the ala of the nose. So there is no local rise of temperature. There is tenderness present on palpation over the left maxilla, and skin over the swelling is pinchable, sir. Sir, next is intraoral examination. The mouth opening is adequate, sir. Patient is edentulous. There is a nicotine stained mucosa over the palate and vestibule. There is submucosal bulge seen over the left alveolar arch, crossing midline by approximately 2 centimeter anteriorly, and also involving adjoining hard palate area with 2 areas of focal ulceration, sir. Rest of the oral cavity and oropharynx appears normal, and on neck there is no visible neck swelling, sir. Sir, next is anterior rhinoscopy I have done, sir. On anterior rhinoscopy, there is DNS, deviated nasal septum right side with the anterior septal dislocation on left side. There is fleshy pinkish proliferative mass seen in the left nasal cavity involving inferior turbinate and seem to be arising from the middle meatus with overlying mucopurulent secretion, sir. The mass bleeds on touch. And on probing, sir, the origin confirmed to be arising from the middle meatus, coming from the middle meatus, involving the inferior turbinate and anterior flora of nasal cavity. Right nasal cavity and nasopharynx appears normal, sir. Next, sir, I will show the diagnostic nasal endoscopy. Sir, diagnostic nasal endoscopy with 0-degree nasal scope was done, sir. There is ASD on left side, so done with the thirdiculum speculum, sir. On examination, there is a pinkish proliferative mass in the floor of the nasal cavity, sir, involving inferior turbinate also. The middle meatus is widened, sir, with eversion of the uncinate process. And mass is abutting the septum, sir. The mass bleeds on touch and the patient is having excruciating pain, sir. So nasopharynx examination is done from the right side. Right side nasal cavity is normal, sir, except there is a DNS on the right side, and nasopharynx is normal, sir. Should I proceed, sir?
What is the status of third pass and roof?
Sir, third pass is
Sphenoethmoid recess.
Hello.
Sphenoethmoid recess and
Sir,
roof.
Sir, sphenoethmoidal recess is there is a no growth, sir. That sphenoidal sinus opening is seen there, but there is no growth or nothing all within normal limits, sir. Sphenoethmoidal recess.
Can you show me the opening?
Sir, here in scopy, sir, I have not that big, sir. I have posted, sir, these.
Okay. So was there associated purulence?
Sir, there is associated purulence, sir. Over the mass, purulent secretion was were there, sir. And purulence was seen in the middle meatus area also, sir.
Okay.
What about infraorbital hyposthesia? Anything?
Sir, the patient is not having infraorbital hyposthesia, anesthesia,
Okay.
loss of sensation, sir. bilateral symmetrical sensations were there, sir.
Okay. What about epiphora or any?
Sir, the patient is having watering of eyes and
So that is very important. Any proptosis, axial or non-axial?
no, sir. No, sir. There is no axial or eccentric proptosis, sir.
Okay.
Yes, sir.
Fine. So basically, it's a lesion of the maxillary antrum left,
Right,
which
sir.
is probably invading the nasal cavity and in the infrastructure into the oral cavity. And upward part, you can feel the infraorbital margin. Well,
Yes, yes, sir. I can feel the infraorbital margin, sir. They are
Yeah.
looking all intact.
Yeah, fine.
Uh,
And there's no trismus, so indirect sign. Although
Right.
it's not a very hardcore sign, but you can have trismus without ITF or PP foci extension. Anteriorly, you feel that the canine fossa is free clinically.
No, sir. Clinically, there is a slight patient is having a tenderness in the canine fossa area, and I can feel some soft tissue underneath, sir. So it is looking to be involved. And in the next slide, sir, I will show the images. And
Yeah, please show the imaging. That's important.
shall I proceed, sir?
Yeah, sure. As far as I'm
I
concerned.
think you had also been asked a question about the discharge at the medial canthus on the left side.
Ma'am.
Yeah,
Yes, ma'am.
Dr.
Yes.
Sikka had asked you about that secretion, and you said you will come to orbital examination.
Ma'am, orbital
So-
examination is next, ma'am. I have not
Okay.
yet completed, ma'am, examination.
Okay. Okay.
Next is orbital examination. Bilateral leads are normal. There is no inflammation or edema. Palpebral aperture symmetric. There is no proptosis or exophthalmos. There is a epiphora present in the left eye and bulge present in the lacrimal sac area. And on pressing that bulge, mucopurulent discharge is coming from the punctum area. The conjunctiva, sclera, and cornea are normal. Normal ocular motility and visual acuity and pupillary reaction normal. Ma'am, then cranial nerve examination. There is a decreased smell perception on the left side. Visual acuity is normal. Extraocular movements normal. Sensation over face present both sides symmetrically. Corneal reflex present. Jaw movements normal. All other cranial nerves intact, and ear examination is normal. Shall I proceed, ma'am?
Proceed. Go ahead.
My case summary is 76-year-old male worked in cotton textile industry for 35 years presented with left-sided nasal obstruction, nasal bleeding, and left side palate ulceration and facial swelling. There is associated left headache, excessive watering from the left eye with decreased perception of smell for the last 6 months. On examination, there is a firm swelling palpated over the left side of cheek. There is a fleshy pinkish proliferative mass in the left middle meatus area, filling the vestibule and the involving the inferior meatal area with mucopurulent secretion in the middle meatus. And there is also irregular submucous swelling of the left upper alveolus and adjacent palate area with focal areas of ulceration. This was my case summary, ma'am.
See, here you haven't mentioned tobacco use. Are you sure you want to focus now on cotton textile industry? Because
No,
you
sir.
don't.
Sir, I have mentioned the patient is a chronic BD smoker, about 20 BDs per day for the last 30 years.
Correct. In the summary, you mentioned that?
Sir, summary may I have mentioned only chief complaints and examination findings, sir.
Yeah, so my question is, what do you think is more important? Is it the cotton textile industry or is it the tobacco use?
Sir,
And in the cotton textile industry, what jobs did he do exactly? Was he exposed to fibers or was he, packing? So all of that's very important.
He was exposed to inhalational aerosol fiber from the fiber, sir. And smoking has an additive effect, sir. With the if the person is having occupational exposure, and smoking is having additive effect with the that.
Okay, so what are all the well-established industrial exposures that cause sinonasal cancer?
Sir, persons working, sir, wood. One is the wood dust, sir.
Okay.
This is a hardwood and softwood, sir. And persons working in nickel, chromium, arsenic industries, sir. They are
Okay.
having more prone to, sir. And that formaldehyde, sir. That also.
Yeah. So these are the ones we don't know. There are probably other industrial exposures, but you shouldn't stress too much on them unless there's data to support it. So we know that there can be chronic irritation into the sinonasal passage from all of this exposure, but you should be a little careful in your exam mentioning any of these things unless there's literature that actually supports it.
Right, sir.
Please go ahead.
Sir, next I will go with imaging, sir.
So when I asked you your clinical diagnosis, you said it's a sinonasal malignancy.
Yes, sir.
I say it's an inverted papilloma. Defend yourself. Let's talk about clinical only.
Sir, it can be inverted papilloma previous, but the history is short, sir. He may be having, sir,
It's a
inverted.
1 year history.
Yes, sir. 1 year history, sir. He may be having some pre-malignant condition before, and which turns into malignancy. Like he may be having, sir, previously that inverted papilloma, and no, it has turned into a full-blown squamous cell carcinoma, and the person is having the short duration history with the that erosion of the destruction of the, sir, maxillary walls and facial swelling and palate ulceration with bleeding, sir. It can be a predisposing factor, sir.
Can it still be an inverted papilloma, or you are sure it's not?
Sir, I have the patient, sir, because the it is causing the that palate ulcerations and erosion of the almost that maxillary walls, and biopsy has also.
So more in favor of malignancy, but you still keep the diagnosis possible differential of IP.
Yes, sir. I will keep the differential diagnosis, sir. In the inverted papilloma will be kept as differential diagnosis in my list, sir.
So very simple. You just say that obviously we need histology to establish
Yes,
a
sir.
diagnosis, but
Yes,
I would
sir.
like to rule out malignancy.
Yes,
It is possible it could be benign, but this is probably how you word it. So exam agrees with you.
Right, sir.
Why don't you show the CT scans that will
Yes, sir.
improve your.
Yes, sir.
Picture towards a malignancy or not malignancy.
Yes,
it's
sir.
impossible to guess the histology.
Right.
Certainly some the direction of a malignancy.
Yes.
So Meet, before we
on
go to radiology, just a word for your juniors: radiology first or biopsy first, and why?
Sir, radiology first, sir. Radiology first, sir, because it will give us an idea about the exact from the representative area we can take the biopsy, sir, because most of the times there are a lot of secretions and overlying polyposis may be there, so we may not be able to take a true representative sample, sir.
Good.
And second, sir, it may cause the that inflammation and edema after, and that may cause the pseudo upstaging. Not it is not not much in sinonasal cancer, but sir, it can also cause the pseudo enhancement around the, sir, main lesion, sir.
Good point. And it may help us rule out certain pathologies or rule in certain pathologies.
Yes, sir.
May not be malignant.
Yes, sir.
Yes.
Also, some sinonasal tumors can be very, very vascular, no? So
Yes.
you would want to know that before you do a biopsy, especially in the OPD.
Yes, sir. Some hemangioparasitomas and that lesion, they can bleed much, sir. So
Correct.
we can
If
have
you
get
do a
an idea.
biopsy in the OPD, you can run into trouble. It's always better to have more information before you touch the patient.
Sir, is my that PAX visible, sir? Scan.
Yeah, we can see it.
Sir, this is the axial CCT PNS neck and chest of the same patient, sir, 76-year-old male patient, going from craniocaudal, sir. Don't, sir. In this cut, we can see there is a enhancement that heterogeneous hyperdense lesion in the premaxillary area. There is involvement of nasolacrimal duct also, sir, and low down, sir, we can see the mass in the nasal cavity vestibule, and with the erosion of the medial maxillary wall, anterior maxillary wall, and low down the lesion, the same lesion extending to the sphenopalatine foramen, and the pterygopalatine fossa appears to be free, sir.
This is not free.
Sir, there is
what you are pointing and what you are speaking are contradictory.
Sir, sphenopalatine area is involved, sir, but pterygopalatine
show me the relation with skin, the lacrimal sac, and the retroentral fat. Is the skin involved? You skipped the skin
no,
part.
Sir.
You said pre. Yes.
No, sir. Skin is not involved, sir. There is a hyperdense soft tissue density in the premaxillary area, sir, overlying the bone, anterior maxillary wall.
Yes, go down.
Erosion of the anterior wall. And, sir, this medial wall is eroded and the middle meatal area is widened, sir.
Okay.
Superiorly, there is a loss of fat plane, no? The skin?
Sir, there is a
See, I'll just tell you one thing that this is a scan where you have a symmetrical, you can compare it with the opposite side also. So if you compare the affected side to the opposite side, you can appreciate that there is definite skin edema on the left side. The skin may not be actually involved, but there is skin edema. Yes. Also, as far as the retroantral fat is concerned and the pterygomaxillary fissure, you're saying that the sphenopalatine fossa is involved, but the pterygomaxillary fissure is not. Compare the two sides and tell us. So you should always look at the opposite side for comparison.
Yes, ma'am. Ma'am, it is just sphenopalatine foramen and just small enhancement there, but the lateral pterygomaxillary fissure is looking free to me, ma'am. That's why I.
And now you're saying lateral pterygomaxillary fissure. The medial part is definitely.
No, sir. I told later on, sir, that sphenopalatine foramen is involved, sir.
I agree with you in terms of infratemporal fossa, but medial part of pterygomaxillary fissure, it seems involved. You can in fact, you cannot discern the pterygoid muscle also on this side. To me, it seems
it's involved. It's involved. There's no doubt.
Pterygoid fossa is involved, sir. Pterygoid fossa erosion is there.
Yes.
And medial pterygoid plate.
1 minute. Use the right terms. What do you mean by pterygoid fossa erosion? There is no erosion. Fossa is a space. So there is fullness or there is a soft tissue there. Right?
Right, ma'am.
Erosion can be of the bones.
Pterygoid wedge erosion.
Erosion you can say of pterygoid plate, but not of fossa. So this part is very, very important. If you look at, sir also meant in he's also mentioned in his presentation that it's almost a difference between being curable and incurable, operable and inoperable. So this part is very, very thoroughly you have to evaluate.
Yes, sir.
We compare the disease side with the opposite side. Follow the posterior wall of the antrum to the pterygoid plates and the thickening of the soft tissue medially.
Yes, sir. Actually, to confirm my findings, sir, that in the pterygopalatine fossa, sir, that we have the patient is also having MRI scans in the next slide, sir. So
In CT scan, can you show us the location of trigeminal nerve, where it should be, and how is it exiting and supplying the infraorbital region? Show us the area of foramen ovale, the foramen
yes, yes,
rotundum,
sir.
and
Yes, sir.
infraorbital foramen, please.
Okay, sir. Okay, sir.
See, one thing is, if you're showing the CT scan, you have to discuss the CT findings. Later,
Okay,
you
sir.
can be corrected based on what you find on the MRI. But when you're walking through the CT scan, stick to whatever you can appreciate on the CT scan. Don't confuse the two.
Sir, this is the region of foramen ovale, sir.
Yes.
And sir, this is the region of foramen rotundum, and this is region of Vidian canal, sir.
Yes. And there is some opacity in the sphenoid.
So,
What do you
yes, sir.
think?
Yes, sir. I just want to tell you, sir. Next, there is a homogeneous opacity in the left sphenoid sinus on the left side, sir. And which most probably, sir, it is not taking an sir,
You feel
contrast.
it's not disease.
Sir, I
You
feel it's
it's a poly. It's a
I
poly.
feel I feel it's a secretion, sir.
Okay.
Trapped secretion, sir, and trapped secretions. Because these are homogeneous and not taking contrast, sir.
And besides, I think the continuity with the main tumor mass is missing.
Yes,
Am
sir.
I right? So you have to interrelate that the main tumor mass, and if the sphenoid opacity is in continuation, you would say that it may be the tumor. But if it is differentiated, you would say that the ostia is blocked, and therefore you will have a secretions. It's
Yes, sir.
important because you should not overstage it.
Right, sir.
So why don't you go on to the pterygopalatine fossa in the axial scans? Just go a little back, and yeah, just show that little bit more in more detail. You're shown the, yeah, go back, go back, go back, go back. What are the boundaries of unresectability in conventional extracranial maxillectomy? And that's what you're zeroing into.
Yes, sir.
Already, Madam Sarbani has told you about the skin.
Yes,
Skin
sir.
is also a bad thing as far as the prognosis and
Sir, then, sir, extensive, sir, dural invasion, sir, intracranial extension, extensive skull base erosion, sir, and nasopharyngeal involvement, sir, and clival involvement. Then cavernous sinus involvement is a contraindication, and internal carotid artery is a contraindication, and gross pterygopalatine fossa and pterygomaxillary fissure involvement is a contraindication.
okay, let me put it another way, rephrase it. What are the extracranial extensions that worries the surgeon that he will not get a R0 resection?
Sir, pterygopalatine fossa involvement, sir.
What about skin? Skin is easy to resurface. The skin that you're seeing very close to the skin of the face. Do you want to resect that, or you don't want to resect that? And what is going to be the problem there?
Sir, skin, if we resect that, we can take a margin, sir.
Yeah. But it makes the surgery that much more technically difficult.
Yes, sir.
And you may not get the margins. You may get a margin, but the prognosis is extremely bad. Skin involvement. And it is a challenge to the, suppose you are planning to do any form of radiation, that will cause a delayed healing. You need to put some fresh tissue there. It really, I mean, it just makes the surgery supra major. Free flaps, all that.
Yes, sir.
So that is it. So you have to say in your presentation that how is this tumor curable, and if curable, what sort of resection you require? Is it possible to be done by anybody and everybody in every center? And what are the other things? Skin involvement, usually the lymphatics get involved. So you have to do a very thorough neck dissection also.
More chances
Some
of
people say
lymphatic
that
spread.
you have to do a neck dissection in this case.
Yes, sir.
So that is what you are zeroing in. Now, can we go on to the MRI? If there's anything significant in the MRI, in addition to complement your CT scan, you can let us know.
Yes, sir. I will show one slide, sir.
Yeah, just tell us what it adds to the CT scan.
Sir, is it visible, sir?
Yeah, it is visible.
Sir, this is the T1 weighted image of MRI, contrast enhanced MRI PNS, sir. The area where it was looking suspicious that, sir, it is looking limited to the sphenopalatine foramen, and there is not looking to be involvement of pterygopalatine fossa and pterygomaxillary fissure, sir.
Agreed.
And sir, one more image here. This is the T2 weighted MRI image, sir. Where we were looking at the sphenoid sinus. It is T2 hyper intense, sir. This is T2 hyper intense here, and these are looking mostly to be trapped secretions.
Okay, got it. So that clarifies your suspicion that it is indeed
Yes,
some
sir.
sort of a osteoblockade leading to some sort of secretions.
Yes, sir.
Okay, now you're done the biopsy.
Yes, sir.
You're sure about the biopsy?
Yes, sir. It came as common cell carcinoma grade 2, sir. Moderately differentiated, sir.
Okay. Suppose it comes as undifferentiated carcinoma, anything else you will ask for?
Yes, sir. You're talking for imaging, sir?
No, and biopsy. Now we have finished the imaging.
Yes, sir. Yes, sir. Yes, sir. If it will come if undifferentiated carcinoma, I will go with the after biopsy immunohistochemistry, sir.
Okay.
And it is a diagnosis of exclusion, sir, and SNUC sinonasal undifferentiated carcinoma.
Anything else? What are the other differential diagnoses which IHC may
yes, sir.
take it, differentiate?
Yes, sir. Sinonasal undifferentiated carcinoma, sir. Sinonasal neuroendocrine carcinoma, nut carcinoma, sir.
Right.
And olfactory neuroendocrine tumor, sir. Olfactory neuroblastoma, sir.
Okay.
These all we have to differentiate by IHC markers. And
no, neuroendocrine and olfactory neuroblastoma, are they same or are they different?
Sir, olfactory neuroblastoma, it comes under neuroendocrine.
Are you sure?
Yes, sir.
I have my doubts. Will somebody else clarify?
Sir, it is sir, high grade that
olfactory neuroblastoma will not come under neuroendocrine, no?
That's what.
You'll have to do the packs, 10 packs, CK40.
Absolutely right. I think that's what I was looking for.
What's the origin of this tumor? The cell of origin for an olfactory neuroblastoma and for a neuroendocrine?
Sir, neural crest, sir. It arises from that.
Now be very specific about. Okay, you're saying neural. You're saying about the
neuroectodermal origin, ma'am.
So an olfactory neuroblastoma, radiologically, or rather on your imaging, you can make some kind of a diagnosis, right?
Yes,
where will it arise from essentially?
Ma'am, it arises from the that olfactory cleft area, ma'am.
Where?
That is in between the ma'am superior meatus and the superior meatus and the septum, ma'am. It is a 1.5 into 1.5 centimeter square functional that area, ma'am. In the roof of the nasal cavity, ma'am. Hello.
Sorry, go ahead.
Yes, ma'am. Ma'am, biopsy came as squamous cell carcinoma grade 2, and my staging according to AJCC 8, ma'am, TNM staging, it is T4A N0 M0.
What about your metastatic workup? What did you do?
Sorry, sir.
Your metastatic workup, you said it's M0, no? What did you do?
Sir, I have done. Sir, I have done that CT chest only, sir. PNS neck and chest.
Okay. Any role for a PET in this patient?
Sir, not much role of PET in this patient, sir. It is mostly for residual or recurrent or high-grade histological tumor, sir. uh, not
Suppose this was a undifferentiated sinonasal cancer, would you do a PET? The question is that. In a 70-year-old guy.
sir, in sinonasal undifferentiated cancer, the METSAT presentation is around 20 to 25 to 30% patients present with MET, sir.
Okay.
And so then I'll go with, sir, PET scan if it is sinonasal malignant melanoma or SNUC or neuroendocrine cancer, sir, high grade.
Okay.
Yeah, so it's not just high grade histology, it's also
Yes.
basically a choice of histology, right? If this is
Yes,
a
sir.
leiomyosarcoma, would you do a PET? Probably, because the propensity for blood spread is more.
Yes, sir.
So how would you manage this person now that you have said? You just summarize what you have seen.
Sumit,
And,
what about lymph nodes also?
Yeah.
Sir,
Yeah.
there are no palpable lymphadenopathy on CT scan also, sir. There are few nodes, sir, around 6 millimeter, 5 to 6 millimeter, 2 to 3 nodes in level 2 area only, sir, that are not significant, sir. Patient is N0. There are no
What are the nodes you should be looking out for such posterior tumors?
sir, for posterior tumor, we should the first echelon is the retropharyngeal node, sir.
Yes. So
Then,
that's what you have to look. Which cross-sectional radiology will show you retropharyngeal nodes well?
Sir, axial cut will show well, sir.
No, which you have done CT scan and MRI?
Sir, CT scan also we can show, but better is to give
Better. I'm asking
better with MRI, sir.
So you should have said in MRI.
Yes.
That would get you more points in your marking.
Yes,
no, your examiner
right,
will give you more marks. So if you say that we don't see any relevant retropharyngeal nodes.
Yes, sir.
Otherwise, is there any other way of identifying retropharyngeal nodes?
Sir, other than imaging, sir?
Yeah, so that's the best you got. Maybe nasal endoscopy, but that's again submucosal. So
yes, sir.
it's just a very, but the CT scan, MRI will definitely show you it hyper intense, and you can see it virtually like headlights, near the torus tuberi and all that area.
Yes,
you
sir.
will see it well formed. So that is important.
Yes, sir.
Just tell me, with this extent of disease that you showed on the CT scan,
Yes,
is
ma'am.
there any other group of lymph nodes that may be at risk?
Yes, ma'am.
Which ones?
Ma'am, other because this lesion is eroding the palate, and whenever the maxillary, ma'am, maxillary, this cancer, ma'am, causing in T2 lesion, as the lesion reaches the hard palate, ma'am, in the buccal cavity, there are more chances of lymphatic spread, and the lesion can go to level 1B and level 2, and sometimes can be in the level 3 also, but mostly in the level 1B and level 2, ma'am.
But in this patient, you've got a central facial edema with erosion of the premaxilla also. So what about the involvement of the buccofacial and the parotid group of lymph nodes?
Yes, ma'am. Yes, ma'am. Prefacial and parotid nodes can also, ma'am, are more prone to this type of lesion, ma'am.
This is the challenge in this patient, because see, he's 76 years old. He's diabetic, hypertensive, and with this kind of a lesion. So you'll have to consider all this when you're discussing management of this patient.
Right, ma'am.
So for
Please go ahead.
Sorry.
Yeah. Sorry.
For a retropharyngeal node, what will your criteria be for imaging to call it positive? And number two, what happens if the retropharyngeal nodes are positive in this person? How does it affect your management?
Yes, sir. Sir, criteria for if the lateral retropharyngeal node is more than 6 millimeters, sir, it is taken as malignant, sir. And any medial node retropharyngeal is taken as malignant, sir.
But what is the incidence of medial retropharyngeal lymphadenopathy? What is involved more commonly, medial or lateral?
Ma'am, lateral is more commonly involved, ma'am.
Yeah, you hardly ever see it is less than 0.1%.
Yes, ma'am.
Okay. Now, since we are running short of time, I think you need to go ahead and talk about. So you have a T4A N0M0 carcinoma of the
Maxillary sinus.
maxillary sinus with extension into the anterior ethmoids, right?
Yes, ma'am.
And involving the nasolacrimal duct.
Yes, ma'am. And
so what is your management? What is your plan for treatment?
Ma'am, I will discuss the management option as the patient is 76-year-old and the disease is, ma'am, resectable. So I will go with the that curative intent, ma'am, surgery with the surgery first, ma'am. And my surgery will be, ma'am, in this case will be total maxillectomy, ma'am, and total maxillectomy and elective neck dissection plus reconstruction.
Say elective neck dissection, what are the levels of lymph nodes that you're going to cover?
Ma'am, at least, ma'am, I will because if I have to plan for, ma'am, reconstruction and I am thinking of free flap reconstruction, then at least, ma'am, level 1 to 3 in this patient should
So
be
your
addressed.
criteria for doing a neck dissection is
Yes, yes, sir.
is for vessel delineation for your free flap.
No, sir. Sir, Berger et al. And some evidences are there, sir. As NCCN guidelines, according to NCCN guidelines, sir, neck dissection should be done only when there is a N plus disease. And various studies are there, sir. One is the with Berger et al. Who took the review.
Why are you doing it here? Why are you doing the neck dissection here?
Sir, because I am planning for, sir, as the lesion is in the palate, sir, T4A lesion, there are more than 20% chances of lymphatic spread, sir. Less than T3, less than 20%, it is T4A lesion, sir. And there is a palate erosion also. One paper by, sir, Cantu et al. That shows that the T2 lesion, whenever the lesion is eroding the palate, sir, there are the chances of lymphatic spread are equally that of the oral cavity. So better you should go for neck dissection in T2
so I
lesion.
get your point. You are saying that since palate is involved, you will like to address the neck.
No, sir, it is a T4A lesion, and I have to if I am planning for free fibula also, sir, I have to open the neck and I will do, sir, 1 to 3 at least.
I have a very pertinent, simple question. If this patient was your relative,
yes, sir.
Okay, would you like to subject him to such a morbid procedure, and with what sort of a life expectancy? You have to also give adjuvant therapy. You cannot just stop with surgery, right? So this guy will be undergoing therapy for at least 3 months, 2 to 3 months.
Yes, sir.
And if he was your grandfather, I don't feel it, take it personally, but I would really think 10 times before subjecting it to something that will give him maximum maybe 1 year of disease control. If you have done enough of these tumors, you will know that. See, the skin is involved, so the lymphatics by thing is involved. The prefacial nodes, the buccal nodes, and the parotid nodes. And then you're talking about level 1 to 3. Then you're talking about a free flap. And then you have to give him a prosthesis, or he's totally edentulous, according to me, the picture that you showed.
Yes, sir.
So it's a big challenge. The quality of life, you have to look at that aspect also. Just because it is NCCN says something, does NCCN talk about a 76-year-old man with other comorbidities? Do you understand my question?
Yeah, understood, sir.
And this patient, suppose he goes to Dr. Prathamesh Payne now that he's in a corporate setup, it would cost a bomb.
Right, sir.
You doing it in Kidwai or doing it in Tata is a different story. But are we going to use our resources for this limited control of the disease? I mean, one is theoretical aspect. I agree with you. But think about the other aspect also, the humanitarian.
Right, sir. Understood.
Economical.
We'll discuss with the patient and family members about all the this pros and cons of surgery and adjuvant treatment, sir, reconstruction,
Yeah,
sir.
that's what
If
I think. You should
after
be very
that,
guarded. You should
yes,
be
sir.
very
After
guarded.
that, after
Yeah.
that, if the patient or attenders are willing, sir, to undergo surgery, then we have to.
I mean, you should be very guarded. That's what I'm trying to say.
Yes, sir.
Let the patient take the responsibility of the decision rather than you pushing the responsibility, your views on him because of the papers that you're alluded to. Those papers are not going to rescue you later on.
Sir, those papers I was just quoting for, sir.
Yeah, I
neck,
know. That's
neck
what
one.
I'm saying. Those I'm
Yeah.
talking to you as now as a surgeon.
Right,
Forget you
sir.
are no longer a MCH PG.
Right, sir.
So that aspect should also come into the picture.
Yes, sir.
So you try to mix both, because tomorrow when he's going to give you the marks to get you out of your MCH, tomorrow you're going to be practicing. So
Right,
you cannot protect yourself with all these papers.
Right, sir.
I think Dr. Sarbani and Dr. Prathamesh should give their opinions.
So I just ask either Kapil Sikka or Narayan, because I think Prathamesh is not around. And
Okay.
yes, what Dr. Shenoy has said makes sense in the practical scenario, but I don't know how you do it in your MCH exams. In our exams, we would rather talk about what may be ideal. The most thing that you'll have to, the most important aspects that you will have to consider in this patient are his age, his comorbidities, and then given the extent of disease, what would be the extent of surgery that you would think about in this patient?
Yes, ma'am.
In this patient, I think these are the factors that you will have to consider before you come to any decision regarding his treatment. All right.
Right, ma'am.
So, yeah, Dr. Sikka, please go ahead.
Yes, ma'am, I'll agree to that. And I personally feel that the posterior extent or the pterygomaxillary fissure area, I will definitely discuss again with radiologist. And you're considering the age and comorbidities of all these situations. Only doing a total maxillectomy might not be sufficient in achieving good margins. If I am convinced that that area is involved, as I feel is, then I will consider the patient for a alternate treatment, not for surgical treatment. But yes, if it is operable, then surgery probably might give best results in terms of survival.
Yes, sir.
I think
So I think
I
what
also
Make a comment on this. If the histology is a squamous cell carcinoma, definitely the prognosis and the factors about the adjuvant and the outcome is definitely important. However, if the histology is a olfactory neuroblastoma or a SNUC or another histology which is or an adenocarcinoma, we may definitely consider for a surgical option, because that will have a very good survival outcome in these patients.
Sir, that we can, in the case of SNUC and sir, that high grade, we can go with the sir NACT, and if the person is a
Yes.
good responder, then
Yeah.
we can.
Yeah, but you know, see again, so in short, what you have to decide is when you see a patient with PNS tumors, as Dr. Prathamesh has already spoken, you need to keep certain factors in mind. First and foremost, most important, of course, is the histology of the tumor, the extent of disease, not just your TNM, but the actual radiological extent of the disease, the anatomical extent of the disease, the histopathology, the age, the comorbidities, and these together will help you decide whether you're going to go the surgical way, the non-surgical way, or non-surgical followed by surgery. Because there are certain histologies, like if you have the SNUC today is not just SNUC, you have several other tumors within the SNUC bracket itself. Then when you have your esthesioneuroplastomas, when you have your squamous carcinomas, when you have your adenocarcinomas, thing what you call intestinal versus the non-intestinal types, you will have to keep all this in mind and then decide whether you are going to do surgery or you're going to do NACT followed by surgery followed by the right adjuvant therapy. Because in this patient, what you will have to keep in mind is he's 76. Even if you can't do surgery, you will have to really weigh the pros and cons of giving him neoadjuvant chemotherapy, you see, because that's not going to be tolerated so well by him. And in this patient, you will also have to think about elective nodal treatment,
Yes, ma'am.
even if the nodes are N0,
Right,
because
ma'am.
of the histology and the location and the extent of disease, right?
Yes,
So
ma'am.
all these things put together in this man, I would rather err on the side what Dr. Sikka has said is correct. If it is resectable upfront, perhaps you may go ahead. But because of the doubt of the disease in the spinopalatine thing, what you call fossa, foramen area, as well as in the pterygomaxillary fissure, you really do not know whether you're going to get R0 resection.
Yes, ma'am.
One way to look at it is if this man is suitable, give him neoadjuvant chemotherapy. If the disease responds and he becomes amenable to surgery, go ahead with surgery and then decide about the optimal adjuvant therapy. But your surgery is also going to be, remind you, extensive in this patient. So all these things put together, you will have to decide. And my thing in this patient would be actually to start with neoadjuvant if he is suitable. But if he is not, then we'll really have to think about what treatment we can offer him. That's my opinion. But I'd ask Dr. Shenoy, Dr. Sikka, as well as Dr. Narayan to tell what you would think would be the right options for this patient.
I
Sarbani,
agree,
can I
ma'am.
add? I'm sorry I didn't join in earlier. I wanted to look at the scans, but maybe I can just take on from where you left. That if the pterygopalatine fossa is suspect to be involved, you need a proper detailed imaging with MRI. An MRI will have to be done to evaluate all the foramina, the median, the foramen rotundum, as well as the other regions of the greater palatine infraorbital fissure. If you feel that this is a squamous cell cancer going into any of these areas, it is not resectable in the context of whether it in the context of prognosis and whether it's worth doing. So your age is an issue, the extent of the disease is an issue. So in all probabilities, you need to counsel the patient that this is not worth resecting, because you will do an extensive surgery, leave behind disease, and have chemoradiation to back you up, which is difficult again at that age. So in all probabilities, you will need to consider other options. Having said that, what Sarbani said about neoadjuvant chemotherapy, the data from MD Anderson suggests that squamous cell cancers being treated with neoadjuvant chemotherapy, you see 60 to 70% response.
Yes.
And the ones that respond go on to do better than the ones that didn't respond. So if you want to select out whether this patient at this age with a borderline resectable disease is worth treating, you might have to consider neoadjuvant chemotherapy and look at a partial responder versus the one with stable or progressive disease. So do a proper imaging, study that imaging carefully, and then take a call whether you want to go for neoadjuvant versus surgery upfront.
Yes.
I think just a point to add from my side. So when you have a patient like this, you have to really look at their ECOG status, especially when they're elderly. You
Yes,
have to have a very well-motivated patient, because keep in mind, even if you do get an R0 resection, they have to complete radiation plus minus chemotherapy. So generally, you have to make sure that it's a very well-motivated, compliant patient before you embark on any kind of treatment. In order to undergo a major surgery like this or induction chemotherapy, neoadjuvant, they're going to need a good performance status. But when it's a high-grade histology like squamous cell carcinoma, and you don't think you're going to get margin, surgery is a disaster, especially in a patient like this who may not tolerate adjuvant therapy. So I think having a prime discussion is very, very important, whether the patient wants to go through 3 months of treatment. We can't write off patients based on age, because if you select patients carefully, they do well. But also, in my experience, patients in the Indian context, very few actually tolerate full dose TPF. That's another problem that we have. We like to think that neoadjuvant chemotherapy really will shrink these tumors well, but most of our patients end up with suboptimal dosing that's split over several weeks and things like that, which is problematic. That's one big issue that we have. I think you really have to look at all of this very critically and have a discussion with the patient and then take a call.
Yes, sir.
Can I just add a little bit? I
Yes, sir.
think the issue here is it's a disease which is the garden variety squamous carcinoma, yes. But it is a disease which is quite huge. I mean, coming to the skin, I have always found that this when the squamous carcinoma comes towards the skin or into the canine fossa, very close to the cheek skin, they are a big challenge surgically also. And they don't do well in terms of disease-free survival. I mean, these are my personal recollection. But if you look large series, I think the best thing would be probably to give him neoadjuvant chemotherapy. You don't have to give him TPF, but you go ahead with neoadjuvant chemotherapy of a better, more tolerant, lesser morbid protocol, and see if he responds very well. You may just consider if you get a partial response like 60 to 70% according to Ahab-Anna's study. So maybe you can just give him radiation therapy and he will maybe having the disease control, radiation plus chemo, I mean. He may be controlled for, over a year or so, which will, give him a much better quality of life rather than get totally major surgery, recovery, and all that costs, both figurative and actuals. So I think you have to be very, very careful making this decision. I would rather err on the side of less morbidity because our resources in this country are not what it is. And in the corporate sector, I already told you, it's going to cost a bomb. And then if things do go wrong, then you'll have to face the music from the patient side. So just understand all these things. So while it's okay in a teaching hospital and all, I agree, you may be able to do, but certainly you have to weigh the cons and the pros and then go ahead. But I would be more conservative after 3 decades of surgery in a teaching hospital. I would be very, very circumspect to do any major surgery upfront. Neoadjuvant is something that has not been explored much, so really we don't have much data, Indian data at least. Prathamesh can probably throw some light on Sarbani if they have got some data on neoadjuvant in sinonasal cancers.
Yes, sir. There is a one study from, sorry.
Yeah, go ahead, Sumit.
There is one study from Tata Group by Dr. Vanita Norana et al. Along with Dr. Prathamesh sir, where they took around 41 patients with the technically resectable and unresectable patients, T4A and T4B patients, and that patients after the induction chemotherapy with the TPF regime followed the median progression-free survival was about 10 months, and the overall survival at the 2 years around 35 to 40%.
So, Dr. Shenoy, sir, we have used neoadjuvant chemotherapy in various settings.
Right.
So what paper Sumit is quoting is the one where neoadjuvant chemotherapy was used for neuroendocrine, esthesion neuroblastoma, and sinonasal undifferentiated carcinoma.
Okay.
And we found that there was a 78% response rate, and most of those patients who were responders became operable. Now, in literature, you are seeing chemotherapy being used for squamous cell cancers, for adenocarcinomas, which are P53. That's the intestinal type adenocarcinomas, which are P53 wild type, and in the esthesioneuroblastoma, sinonasal undifferentiated carcinomas. So we are in the last 10 years, we are seeing a sea change in the way we are managing these. So if your orbit is involved, if you got an extensive brain involvement, you know that the prognosis is poor. And also be a more morbid surgery. So if you give neoadjuvant chemotherapy, you might change your plan of surgery. You might bring them into the realm of cure. So we know that if you have molecular signatures such as P53 being looked at, Your intestinal type adenocarcinomas, if they are responders, do have 100% survival. And in 2011, Lisa Licitra's group has shown this data. The sinonasal undifferentiated carcinomas today, we do not do upfront surgery. We, after having diagnosed them and ruled out a SMARCB1 and nut carcinoma, if they are truly SNUCs, and you give them neoadjuvant chemotherapy, and there's an 80% response, all of them will be sent for chemoradiation. If there is sinonasal SH neoblastoma, you should want to look at whether it's a Kaddish C and whether it's a higher Himes. A Himes 3 and a Himes 4, Himes 4 sometimes behaves like a neuroendocrine tumor. In those patients, there's a higher propensity for distant metastasis and local failure. So in those patients, if you are dealing with a Kaddish C, which means a more extensive surgery, you should consider neoadjuvant chemotherapy.
Correct.
So again, we are finding that we are trying to look at a group of patients that might be today more extensive in outcome in resections and maybe poor in prognosis because of distant metastasis. In those, we might have a change in our management, save more orbits, reduce dural resections, and maybe avoid distant metastasis. Sarbani, anything you want to add?
Not really, because you have to understand that whatever modality of treatment you use in this patient, it will have to be combined modality, right? So if you use NACT followed by CTRT or NACT followed by surgery, you will have to consider giving adjuvant RT or CTRT. But in this particular extent of disease, you will also have to remember that this is a high-risk patient. You will have to do some form of elective nodal treatment, whether you do surgery or whether you do radiotherapy. So all this will have to be considered in the perspective of the fact that this is a 76-year-old man with comorbidities. All this has to be considered together when you're deciding on treatment in this patient. And also in this patient, there is a question in the chat about the involvement of retropharyngeal lymph nodes. Now, the point is with retropharyngeal lymph nodes, I'd asked the surgeons how many of them would like to go with upfront surgery. I don't think any of them would. Then will have to be covered with radiotherapy only. And in the radiotherapy volumes, I would also take the buccofacial lymph nodes and perhaps the superficial group of parotid lymph nodes because of the extent of the disease anteriorly and laterally, and with that skin edema there. So at least on the ipsilateral side, I would want to do it. And the retropharyngeal lymph nodes, level 1B and 2, you're going to sample if you do surgery. So I would know about this, and this would have to be considered at least to low doses of radiotherapy if they are not involved grossly or on histopathology. So all these things will have to be kept in mind for this elderly gentleman. The other thing that this man will have to be counseled about is the morbidity of treatment, because that is very important for this patient, okay? Because the he's 76. Again and again, I'm talking about 76 because the 76, as I think Narayan mentioned, it's not something that is a definite no, but at the same time, you have to keep in mind his physiological age and not just his chronological age, and then decide based on the extent of treatment. So I think that would be my take on this patient. And yeah, that's all from me. Yeah. Asim, can we close or are we to continue?
Yes, ma'am. I think we can close now. Thank you so much. Thank you, ma'am. Thank you, Prathamesh Bhai sir. Thank you, Dr. Sarbani madam, Dr. Kapil Sikka sir. And thank you, Ashok Shenoy sir, for your valuable inputs.
Thank you.
Thanks a lot, Sumit, for joining in. Thank you, everyone, for joining. We'll be coming back once again after 2 weeks.
Thank you.
And in next month, we'll also be having a roundtable session on the management of the neck. So it will be a 3-hour session on the last weekend of July. To see you all there. And,
Thank you.
have a great
Thank you.
Okay, thank you, Asim.
Okay, thank you.
Wonderful
Thank you.
academic.
Thank you.
Well
All
done.
the best, Sumit. Yeah, bye.
Thank you.
Good night.
Thank you.
Good night.
Thank you.
All the best, Sumit.
Thank
Well
you,
done.
sir. Thank you, sir.
Thank you, Asim.
Yeah, thank you, ma'am.